So this is it is like a general presentation of the gastrointestinal tract. You know that this is these organs are hollow or they have a lumen. So have a lumen, and the lumen is lined by a mucosa, and the mucosa in most of these organs it is glandular because it has a secretory cells, except the mid and the upper esophagus, which are lined by squamous epithelium. Then we have, of course, the mucosa is composed of the lining epithelium, and then we have a lamina propria. Below that, we have a muscularis mucosa, just a small rim of smooth muscle. And this is the third part of the mucosa. And then after the mucosa, we have a submucosa. After submucosa, we have muscularis externa or muscularis propria with longitudinal muscles and circular muscles in a general. But you know that in the stomach, we have also oblique muscle. So in the stomach, we have 3 layers of muscle within the muscularis propria. Then we have a serosa, which has epithelium as to the surface, and between the epithelium and the muscularis externa, we have a connective tissue. So that is a general presentation of the gastrointestinal tract from esophagus up to the rectum. Of course, there are other organs we'll discuss after, which are part of the alimentary tract or system or digestive system, such as the pancreas, liver, and so on. So these ones we'll discuss in another presentation. Of course, the oral cavity also, it can be considered as a part of head and neck pathology, and we will discuss it in that section. So whenever you have a question, you will just ask. So this was introduction. So we start with the esophagus. So I will skip the anatomy, histology, and the physiology of these organs. You will read in the presentation. We have some data on this. You will read them because I cannot repeat. It is just for you to just quick remind yourself about what you have read in these respective courses. So the diseases of any organ, as I said in pathology, we classify them in non-neoplastic diseases and neoplastic diseases. So in non-neoplastic diseases, we have developmental abnormalities, meaning problems which arose during embryogenesis. And then we have inflammatory conditions, which include infections. And then we have other like tumor-like lesions, which are not a tumor but looking like tumors. Then you have neoplastic diseases, among which we have benign tumors and malignant tumors or cancers. So here we are showing some anomalies, non-neoplastic anomalies, and here most of these they are just developmental anomalies. Webs and rings, these are abnormal structures within the esophagus, and they can cause problems in the digestion. So we have atresia. Atresia, you know, it is when there is a part of the organ which is missing. So there are some children who are born without having a continuous esophagus, meaning that they have a short esophagus, sometimes which is connected or continuous with the trachea, and you understand the consequences. So when there is no communication between the stomach and the esophagus, the consequences is that when there is a breast milking, when the child is breastfed, then the milk will go to the lungs, and these children, they will not survive. So achalasia, there is like a constriction of decreasing the caliber in a section of the esophagus. There is a glycogen acanthosis. This we see mainly on a histology, but it can have a clinical implication. Acanthosis, it just means the squamous epithelium is very thick. So it is not a cancer. There is a kind of hyperplasia of the squamous epithelium. So with many layers of cells as compared to the normal conditions, and specifically in this scenario here, this is also accompanied by glycogen within these cells. So they are full of glycogen. There are cystic lesions. These are like masses which are filled with fluid. There are diverticulae. These are so polyp is like a nodule within a lumen or on the surface of the skin, for example. And the diverticula is like an opposite. So it is not a mass within the lumen of esophagus. It is instead an outpushing of the mucosa. So the mucosa tries to form something we can call it like a perforation. Then it enters into the esophagus, and you can see it even when you are looking at only the outer surface of the esophagus. So these are the diverticulae, and they exist in other organs, as we shall see, for example, in the urethra, and so on. Heterotopic gastric glands. Here it means you can see some gastric-like tissue or glands within the esophagus, and this I have seen few of these cases here in Rwanda. So as you see, these are mainly developmental abnormalities. So here we have inflammation, esophagitis. It can be due to reflux, meaning when the gastric acid comes back to the esophagus, and sometimes the acid arrives in the oral cavity. And then there is esophagitis, which is not caused by that reflux. It can be chemical. For example, if someone has ingested corrosive chemicals, it can be due to radiation, has received irradiation for any head and neck or chest mass or tumor. It can be due to infection. I hope you have learned the HIV things, and you have seen that these patients, some of them, before maybe the wide use of antiretroviral drugs, these patients they are having problems of candidiasis. Candidiasis is a fungal infection, opportunistic disease, mainly in the HIV patient, in HIV positive patient. So, but we have many other infections which can cause this: viral infections, bacterial infections, and so on. So there are varices. I think you remember what we learned in vascular pathology. So varicose veins and so on. So varices, they don't exist only on the legs or lower limb or anogenital area. They also exist in the esophagus, and this is a very dangerous disease because it is one of the causes of sudden death. Because if someone is having esophageal varices, usually these are patients who have problems in their liver, and the problem arises when there is a rupture of these varices. The patient will bleed abundantly, and the bleeding, of course, will be internal. It will be going to the stomach, intestines, and when melena comes, usually it is at the end stage. So usually the patients will die before even melena appears. So when you receive a dead body with an unknown cause of death, also think about this, especially if the patient has a history of for example, portal hypertension or any other liver problems. Other diseases are metaplasia. So metaplasia, as you learned in general pathology in cell adaptation to injury, should not be a big deal, but in the esophagus, it is a big deal because when the squamous epithelium of the esophagus cannot withstand the acid, the gastric acid, which comes back there through reflux, then the epithelium will change its status. So it will become Barrett, it will become intestinal type of mucosa, meaning there will be columnar epithelial cells with some goblet cells and so on, or mucus cells. So just like it is in the intestine. So when we see this, it means the patient has undergone a reflux, gastric reflux for a long time. The cells have changed, and when we see this, we don't just say it is a metaplasia. As a matter of interpretation, the clinicians or know when we say Barrett esophagus, it means it is already a precancer lesion. So when there is this one, it is a precancer lesion. So another, it is a sebaceous gland metaplasia, so which is not a precancer lesion. It is when there are some sebaceous glands. You know, sebaceous glands should exist in the skin, around the skin, within the dermis, but they can appear here, and the cause unknown. So there are now neoplastic diseases. They can be epithelial or non-epithelial. So when it is epithelial, you know, when it is benign, we use papilloma, or squamous cell papilloma, or fibroepithelial polyp, sometimes it is named as such. So a cancer from the squamous epithelium will be called the squamous cell carcinoma. Then, if it arises from the glandular epithelial cells, like after Barrett's esophagus, we call it adenocarcinoma. We have a few cases whereby you have adenosquamous carcinoma. It means you find a nest of cancer, but within that nest, you have both squamous and the glandular components. So in that case, we call it adenosquamous carcinoma, and we understand that treating it is very not easy. So others are small cell carcinoma, and when we say small cell carcinoma, it can be of neuroendocrine origin. And otherwise, if it is not from neuroendocrine cell, it harbors a very bad prognosis. Whenever we say small cell carcinoma, especially if it is from the lungs, it is very deadly and not treatment in most of the countries. So the diseases, the neoplastic diseases which are from mesenchymal tissues, meaning non-epithelial, we have leiomyoma, smooth muscle tumor, benign, granular cell tumor, fibrovascular polyp, and the other tumors are lymphoma, plasmacytoma, meaning from plasma cells, and we have malignant melanoma or melanoma, and metastasis from the other organs. So that is in general the discussion. Of course, we cannot mention all of them here because a list is very long. But if we say leiomyoma, it means you can also have a leiomyosarcoma and so on. You can have also neuroepithelial tumors or tumors of nervous origin. We can have them also there because we have nerves throughout the esophagus. So we see one case, a real patient that we received. This was a 74-year-old male who was admitted for hematemesis. Hematemesis, you know, it means vomiting blood, with progressive dysphagia or troubles, troubles in swallowing, anorexia, weight loss, and epigastric burning pain. So whenever we say epigastric burning pain, you will hear something related to gastric acid. So as his antecedents, he was a long smoker, and he also has been using alcohol for a long time. So investigations which were done so far were endoscopy, and of course through endoscopy they took a biopsy for pathological examination. So in histology, we have received 3 very small fragments of tissue because these are tissues taken by the endoscopic machine, so they are always very small. So on histology, we found several fragments of tissue with diffuse infiltration of the stroma by solid nest of tumor cells with abundant keratin pair formation. So when you say there are tumor cells which are making a solid nest, automatically this, for us, it refers to a carcinoma. Especially when it is solid without glands, it means it is a squamous cell. When there are lumens or glands, it means it is adenocarcinoma. So this was solid, and then having a keratin, it is a confirmation of the squamous origin. So conclusion was invasive squamous cell carcinoma, well differentiated of the esophagus. So we discuss now this case. What is squamous cell carcinoma of the esophagus? First of all, it is the 9th most prevalent cancer worldwide. So meaning that it is a frequent cancer. The incidence increases is increasing with a shift from squamous cell carcinoma arising in the upper and the middle esophagus to adenocarcinoma in the distal esophagus, such as in the US and France and so on. So it means the carcinoma in the general esophagus, both adenocarcinoma and the squamous cell carcinoma, they are increasing in incidence. But in some countries, now the adenocarcinoma is being more diagnosed than a squamous cell carcinoma. Of course, in those who smoke, the squamous cell carcinoma will be the most. But those with gastric issues now, they will have, meaning they have a reflux, gastric reflux, they will be more prone to develop adenocarcinoma. So, the problem with these cancers, they are asymptomatic in the early stages. If it could be painful in the early stages, that would be helpful for the patient to come to hospitals as early as possible. But this is not the case. And it is the same for most of the cancers, even the breast cancer. In the beginning, it is completely asymptomatic. You just have no sign, except when the lady examine herself and see that maybe the both breasts are asymmetric. It is when she will say, I think there is a problem. But there is no pain. So esophagus as an internal organ that nobody sees then, they wait to have signs and symptoms in order to come to hospital. And usually they present at the hospital at advanced or metastatic disease whereby they cannot be treated with curative intent. They will just receive palliative care. The cure rate is less than 10%, meaning that those who are completely cured, they are less than 10%, and this is similar to lung cancer. So the overall 5-year survival rate, meaning that if you have 100 patients with esophageal carcinoma, after 5 years, only 14% will be surviving. But when surgery is done, at least after 5 years, 47% of them will be still surviving. And here, the surgery of the esophagus is very cumbersome. You know where its location in the anatomy. For the lower esophagus, it is easier because they can go through the abdomen, but in the mid and the upper esophagus is very difficult because, as you know, the esophagus location is just behind, just close to the vertebra, so it is not an easy area to access. So it metastasizes usually to the liver, lungs, and the pleura. So the treatment is usually chemoradiation, which may achieve similar results to surgery, meaning that if chemoradiation, it means you give at the same time chemotherapy, drugs, and the radiation, and the radiotherapy at the same time. And it is assumed that the results are almost similar to those of surgery, but you see that those who undergo surgery, resection of the whole mass, they have a better survival in general. So the differential diagnosis will include the reparative processes. So if you do endoscopy and you find something abnormal, don't rush to say it is a cancer. It can be just a reparative process. For example, if the person has had many episodes of burn, of esophageal burn, for example, he or she has ingested corrosive chemicals, she may have the scars there, and don't rush to say it is a cancer. Just check if it is not a scar. Also, sometimes even on histology, there are chemoradiation-induced atypia, meaning, for example, a patient may have undergone chemoradiation for head and neck cancer, thyroid cancer, and so on. Then, if they do biopsy of the esophagus, pathologists can misdiagnose this as a cancer, while the atypical cells are just reactive to the chemotherapy or radiotherapy which was given before. So that was in general the carcinoma of the esophagus, combining both adenocarcinoma and squamous cell carcinoma. Now, because the case we had here is a squamous cell carcinoma, we go into details about squamous cell carcinoma. So it has a highest incidence in developing countries. As you saw in the previous slide, the developed countries, now they are shifting to adenocarcinoma instead of squamous cell carcinoma. So there may be reasons that we don't know, but for what we know, the risk factors of this include, as you see here, the causes or risk factors. They are lack of fruits and vegetables. And unfortunately, the developing countries, they're the ones which have the capacity to produce the fruits and the vegetables. But maybe our population is not aware that these fruits and the vegetables are very helpful. So in Europe, because of the climate and in Northern America and the other such countries, it is not easy to grow fruits or vegetables because of their climate. So they import them from other countries, but those countries which produce these vegetables and fruits, they don't know how to use them. And for the matter of fact, you know that in Rwanda there are some districts with malnourished children, and when you see there's a district, most of them they are the most rich district in matters of agricultural products, such as Burera district. They produce almost everything, but they have the highest incidence of malnourished children. So meaning that a kind of education is needed to our population to know how to use what we have. So the lack of fruits and vegetables will cause a deficit in vitamin A, B6, C, riboflavin, thiamine, and zinc. And these deficits are one of the causes of developing this esophageal or squamous cell carcinoma. Alcoholism. So those who take Rica, they have a 25-fold risk of developing squamous cell carcinoma of the esophagus as compared to those who don't drink alcohol. Tobacco also, it is known, and when now someone takes both tobacco and alcohol, the risks increase. So there is a synergistic action of both. So betel nuts, these are things that they look like okay, arachide in French, I don't know how to call it in English. So they look like the same, almost the same, but these are produced by big trees, and they are mainly seen in hot African areas, especially around or on the coast of sea, such as Indian Ocean. So fungal contamination of foods, hot foods and beverages. Maybe this is the reason why the people from China and especially India, they have a high risk to develop this carcinoma because they drink very hot tea and so on. Maybe also the Muslim countries. So the nitrates and the nitrosamines in molecular basis of cancers, you have seen that these are one of the risk factors of gastrointestinal cancers. So the problem is that when you you eat foods which are pre-cooked, those you buy from supermarkets, they put nitrosamine in them so that these foods can be preserved. So the problem is that when now you ingest nitrosamine, when it arrives in the stomach, in the gastrointestinal tract, it will be transformed by the gut bacteria, normal flora, into nitrates, which are carcinogenic. There are also polycyclic aromatic hydrocarbons, which are produced in China. And also those are living in an urban environment. So urban environment, maybe itself would not be the cause. The problem is the lifestyle of those who live there. So they tend to eat less fruits and vegetables and eat more of these, for example, pre-cooked foods bought from the supermarkets containing nitrates and nitrosamines. And maybe they are the ones also drinking very strong alcohols as compared to those living in rural areas. And also they eat as I said, they eat less fruit and vegetables and more fat. So other factors include, so you see that the first category and the second category, they are things which we can control. So the third category, there are predisposing syndromes which you cannot control easily. So these include achalasia, celiac disease. Celiac disease is a condition whereby someone has intolerance to gluten, for example. So you cannot eat maize or things like that. So I know somebody, and the problem with it is that sometimes you are born normal, but when you are adult, then you start to develop these things. So in a research group I belonged to when I was in Sweden, we had two ladies who had this problem, celiac disease, and one was a black from America, and the one is just from Europe, and the one from Europe, she just developed the celiac disease when she was there. She was studying in Sweden. So meaning that someone can develop it when he or she is adult. So others are corrosive strictures. So corrosive strictures, they can be due to anything. But what you understand, corrosive, if someone has ingested corrosive acids and so on, they will develop a stricture, meaning the lumen has been narrowed. There is another condition called epidermolysis bullosa. You will or have learned it from in dermatology. And when we see dermatopathology, maybe we'll talk about it briefly. Epidermolysis bullosa, I think from the name of itself can understand what happens. There is epiderm, then lysis, it means there is a destruction of the epidermis and producing bulls or big vesicles. So these are people who will have their epidermis detached from the dermis, and when they are detached, the created space will be filled with fluid or just a gas. And it is a terrible disease when you see someone having it. So the problem is just very simple when it comes to histology. It is because they have their desmosomes, as you have seen them in histology, they have been destroyed. So their desmosomes are lacking or destroyed. Therefore, the epidermis is detached. So it have seen then that people having that syndrome, they tend also to have a high risk to develop squamous cell carcinoma of the esophagus. Of course, it is not known how these could be linked. There is also esophagitis, a chronic esophagitis, such as those having reflux, or it can be due to bacteria, such as HPV, human papillomavirus, and so on. Okay, it is written in HPV. Those who have undergone a radiotherapy for any other reason, cancers, treatment. Squamous carcinoma of the other aerodigestive sites. So if someone has developed a squamous carcinoma of the oral cavity, also this will have a high risk to develop also the squamous carcinoma for the esophagus. So there is a tyrosis pulmonaris and the plantaris. This also is this. It is like a congenital disease, and it manifests by abnormal appearance in the palms of the hands and in the sole of the foot. And this will be rarely associated with Barrett's esophagus, because the Barrett's esophagus is just linked to adenocarcinoma, not to the squamous carcinoma. So it is known that this cancer affects mainly males. And maybe one of the reasons is that males, they are the ones who drink more and who smoke more than others. Males and who are aged at more than 50 years of age, and you understand the case we discussed from this presentation. He was a male and he was 74 years, so he fulfills both of these, and he was a black, of course. And they said that when you compare blacks in the United States with the whites, the blacks, they have four-fold more risk of developing this cancer as compared to the whites. So usually the reasons, the pathomechanism is not known. It is not that there is a link or it is a risk factor, but to link it to the molecular aspects of cancer or for oncogenesis, it is not known. So what are the signs and symptoms? The patient will present with dysphagia, anorexia, and weight loss, especially if the patient is at the advanced stage of the disease. And they understand also our patient here had both or these three signs. Usually there is invasion of the muscularis propria at presentation, so meaning that the cancer has gone from mucosa to submucosa to muscularis propria, meaning that it is advanced, really advanced. In resection specimens, it was found that from 30 to 40% of them, they had already adjacent mediastinal invasion, meaning that it has gone beyond the esophagus. And in 50% of them, there was a lymph node metastasis, which can be periesophageal or cervical lymph node. And some of them, they have a metastatic to gastric submucosa. And when you find a squamous carcinoma in the stomach, it can't be from stomach, because the stomach does not have squamous cell. So we always think it is from another organ, such as esophagus. So the distant metastases go mainly to the lungs, the liver, bones, and the adrenal glands. So this cancer is associated with very poor prognosis. The median survival is less than 1 year. So meaning that some they can go beyond 1 year, but most of them it is less. Explorative cytology is accurate, especially in the lower third of the esophagus, and his cytology and the biopsy are very more helpful. So explorative cytology, last week you have learned about cytology. It means you just scratch cells from an organ and you examine them. For non-explorative cytology, it is when you use, for example, a needle to do final needle aspiration to get cells. So there is a pattern or a variant of this cancer, which is varicoid, meaning that when you do endoscopy or you do surgery, it looks like a varicose. You can think they are varicose veins. So there are problems that they disseminate via vascular vessels and the lymphatics to the submucosa. So the prognostic factors, meaning the factors which determine who will maybe survive longer or who will not. This is a stage. So, of course, if the stage is advanced, more likely to die as early as possible. Grade is not very important, but when it is anaplastic, meaning that you cannot really know the types of the cell, then it becomes a factor to prognosis. So in treatment, first of all, you do preoperative radiation, meaning that before surgery, you do radiation. So, and this is done in many other cancers, such as breast and so on. So you must understand the reason. Because last week there is a doctor who wrote to me, he's not in Rwanda. He wrote to me that he has a relative, she has a breast cancer. Now, after diagnosis, they said that the patient must take radiotherapy and chemotherapy before surgery. And he was very sad, asking me why this should be done. And I told him this is a protocol. When a cancer is very large, they don't do surgery straightforward. They give radiotherapy and chemotherapy in order to decrease the size of the tumor to make it more operable. So we call it downstaging. So here also it is done for the esophagus. Then after that, esophagectomy can be done, and variably chemotherapy. So chemotherapy can be given or not. So mainly, a squamous cell carcinoma of any organ, they are treated with radiotherapy, with some exceptions. So that is in general what is done for the squamous cell carcinoma of the esophagus. So when you do surgery or autopsy, this is what you see. You see that it is a fungating mass. You cannot, the surface is no longer smooth. So a fungating or exophytic or purpuric lesions, this is the most common presentation. In other cases, you can see just ulceration. Ulcer, you can think it is just an esophageal ulcer. And when you take a biopsy, they will tell you, no, it is just a cancer. It can be infiltrative, intramural, causing a thick, rigid esophageal wall with luminal narrowing. So this also happens in the stomach, and we see many of these cases at South Africa because maybe it is the main center for endoscopy. So we receive many cases whereby there is a cancer, but you cannot see on the surface, either outer surface or the lumen of the organ. Why? Because the cells infiltrate intramurally, and the patient will come just because the lumen has decreased in its caliber or diameter, therefore bringing about the dysphagia and so on, and maybe also having anorexia, having loss of weight and so on. So, and when you do endoscopy, usually nothing. But when you do biopsy, a deep biopsy, then they tell you, yeah, this is a cancer. And when we do surgery or when they bring a whole organ to us, when you palpate, you feel that the wall is very hard, or it's very hard, like just a tree. So that will be a sign even before histology that this is a cancer. So that condition before was called rhinitis plastica, but this term is no longer in use. So on histology, on the left side here, we can see a squamous epithelium. Then we have the lamina propria, but it has too much inflammation. So this is benign, but here you see that the squamous cells, they have infiltrated below in the lamina propria and probably gone further. So here there is a cancer on the right side, on the left side, there is no cancer. So how do we stage esophageal cancers? This is the American Joint Committee on Cancer, something like that. But it is in just the TNM staging that you know. T meaning tumor, N lymph node, and M metastasis. So when the tumor is just only in the lamina propria or submucosa, we call it T1. When it arrives in a musculus propria, it will be T2. And when it arrives in the adventitia, it will be T3. And then it will be T4 when it invades adjacent structures around the esophagus. So it depends. If it is on the anterior wall of the esophagus, it will infiltrate the trachea, for example. So, but what as clinicians, they take decision based on is the stage. But to have this stage, you have to depart from these data. So that's why for us in histology, they are the ones in histopathology to give the data on these two, lymph node and the primary tumor. So metastasis, it will be mainly radiology or in a clinical examination if they see that the liver and so on is involved, or the trachea, for example. And then the clinician will have to merge all the data from histology, radiology, and the clinical data to have the stage. And then they take a decision depending on the stage. So you see that it will be stage 2, especially when there is involvement of a regional lymph node. That will be in stage 2B. And so on stage 3, it is when there is T3 and lymph node involved. Then stage 4, whenever there is a metastasis, we say the patient is at stage 4. So that is in general. And this is a general concept to almost all the organs, but of course there are some differences. But as a basis of interpreting this, when you have a metastasis or lymph node involvement, it means the stage of the disease is more advanced, and more likely this patient will not be cured. He or she receive palliative care. So if then we compare the findings in our clinical case and to the literature that we have just read, the esophageal site and the aspect of the region were not specified by the surgeons, and this is a big problem because they should say the tumor was from the upper esophagus, mid esophagus, or lower esophagus. They didn't. So this is a problem of incomplete data. So as clinicians, when you take specimens or whenever you are referring your patient to another doctor, you must be as complete as possible when you give information. So they gave just 3 biopsies, and the international standards is that they should take at least 5. So the stage of the tumor ought to be highlighted after the first histology result is issued. So because this patient had a small biopsy, then after the small biopsy, they should have staged the tumor before other procedures. But it seems when we looked into archives, this was not yet done. And this is the work of the clinicians, as I explained, because he's the one to merge the data from histology and radiology, such as MRI and so on. So any questions so far before I ask my question? Any question? Okay, so it seems no question. So you can just type into the chat. The first question, name a precancerous lesion of the lower esophagus. I mentioned it many times. The second question, name the most frequent cancer of the upper and the middle third of the esophagus. Just so I think 1 minute is enough. Okay, so I saw someone that has typed. So the precancerous region of the lower esophagus, as I said, is the intestinal metaplasia that we call also Barrett's esophagus or Barrett's disease. So the most frequent cancer of the upper and the middle third of the esophagus is squamous cell carcinoma, while the most frequent cancer in the lower third will be adenocarcinoma. Okay, so we go on. Any questions so far?
I didn't get the last question.
Sorry?
You can repeat the second question, the answer for the second.
Okay, you have it in the chat. There's someone who answered. It's squamous cell carcinoma. If you had asked about the lower third, then it would be adenocarcinoma. But here we said middle and the upper. So it is squamous cell carcinoma. Okay, so there's no question. Then we go to the next section about the stomach. So for just anatomy, know that the stomach has a cardia, which is close to esophagus, then a fundus, a body, pylorus, and the antrum, of course, antropyloric region is the same. Then pylorus is itself, pyloric sphincter, and then the duodenum in the downstream. So you know that on histology also there are differences on how the glands appear in these parts. So the body and the fundus, the histology is almost the same, and you see how they are. They have a long pit here, how their pits appear, and their gland has pit, and isthmus, neck, and the base. And this is just in the body, and the fundus is almost the same. For the antropyloric region, it is almost the same, but you see how the glands themselves they appear. So it seems in the antropyloric region they are smaller than those in the body. And the main reason is that in the body we have what we call parietal cells. These are reddish cells on histology. Parietal cells, they don't exist in the antropyloric region. That is the main difference. So when we see biopsy for us, it is very easy to say this is antropyloric or this is just a body from fundus or the body of the stomach. And then cardia and the antropyloric region on histology, they seem almost the same because they don't have parietal cells. The difference is that the glands in the cardia are smaller or shorter than those in the pylorus. So for the classification of the diseases, you have non-neoplastic anomalies such as hypertrophic pyloric stenosis. And you know, this is a disease which affects mainly young children around 5 years and so on. And when you palpate them, so they will have a severe abdominal pain. The food will not pass through the stomach, from stomach to the intestines. So they have abdominal distension, but they have a very painful nodule that you can palpate. And in French, that sign we used to call it olive pylorique, because it looks like just a flute when you palpate it. So there are the diverticular, I explained them, and the heterotopic pancreas. So here it means sometimes we find structures of the pancreas within the gastric wall. I think I have seen only one case at Africa. So, and then there is gastritis, and you know, this is a disease which affects many Rwandans. So it can be acute or chronic. And when it is caused by Helicobacter pylori, usually it is chronic. It is always chronic when it is by Helicobacter pylori because it is discovered after many weeks of onset. There is also gastric ulcer, which can be acute or chronic. So ulcer is usually chronic, but it can be acute when someone has a very severe stress. For example, if someone undergoes a very wide burn injury, so umuntu wahiye cyane akenshi ahita agira gastric injury kubera uburibwe aba afite ku mubiri bituma n'igifu gikora acide va agahita agira ulcer ako kanya. So ni ibintu bitoroshye gusana ariko bibaho, umuntu akaba yarasanzwe nta kibazo afite akahita develop ulcer, and sometimes it is perforated within just a few hours. So these are some of known neoplastic diseases, and others are hyperplasia and polyps. So we have many kinds of polyps: hyperplastic polyps, phonic gland polyp, polyposis syndromes, inflammatory fibroid polyp, and so on. So for the neoplastic lesions, we have epithelial, meaning you have a polyp, and we have adenocarcinoma. So as I said, we cannot say we have a squamous carcinosis primary from the stomach because we don't have squamous cells there. So mesenchymal one, we have leiomyoma, and you have lymphomas and gastrointestinal stromal tumors. And maybe here, okay, it is below there. So gastrointestinal stromal tumor is the most common known epithelial cancer that we see in our settings. There are many cases in Rwanda. So also it is usually difficult to diagnose them because they don't appear on the surface in the mucosa, on the lumen, because they arise from muscularis propria or submucosa. So they are diagnosed when they are advanced. But for some lucky patients, their tumors are not cancer. Some they are almost benign. Others are intermediate grade tumors. Others are ovary, very aggressive cancers. For us, when we diagnose them, there is a marker we look for. We call it c-KIT. Maybe it is a gene that you know. So when we see that c-KIT or CD117, when it has a mutation, then these patients, they will receive a treatment called the Groovec. It is a treatment there to inhibit the tyrosine kinase that, you know, it is one of the pathways used by second messengers when they bring information from the receptor to the nucleus. So when there is a mutation in that tyrosine kinase, and this patient, they receive the specific treatment for that, they have high chance of being cured. And these drugs are available here in Rwanda. Others are lymphomas. So there are many lymphomas we see in the stomach. So other tumors are carcinoid. Carcinoid, it means these are tumors arising from neuroendocrine cells. And as you know, in the stomach, we have many endocrine cells. And I think in the secondary school, we have learned that the first endocrine cells or glands which were described were from the stomach. Though they don't form a large organ, but they are there, producing different hormones, such as those which produce gastrin and so on. Then glomus tumor, it is a vascular tumor. So we have a case study. This person was a 28-year-old male admitted for acute abdomen. His history is that he had the epigastric burning, and the pain was worse at night, but the pain was decreasing with taking food. So 24 hours before the admission to the hospital, he had a severe generalized abdominal pain. He could not pass gas, stools, and when you say this is what you call acute abdomen. When someone has severe abdominal pain and he cannot pass gas or stools, it means it is acute abdomen. There is the obstruction somewhere. He had also vomiting and anorexia. So it is usually this happens usually when someone has an acute abdomen and they have also vomiting. So abdominal X-ray was done, and the differential diagnosis was peritonitis secondary to perforated gastric ulcer. And you know that whenever there is a peritonitis, for any reason, whenever there is something causing inflammation within the peritoneal cavity, the stomach and the intestines, they stop working. So no movement, peristaltic movement will not happen. And this explains why this person could not pass gas or stools just because of the perforation of the gastric ulcer. With perforation of a gastric ulcer, you understand there is an acid from stomach which leaked in the abdominal cavity. There is a food which went there, bacteria, and so on. So as a treatment and management, they did the laparotomy, meaning they have opened the abdomen and they just to see what happened and the repair. And they have taken a biopsy for examination. So on gross examination, they just brought small brownish red fragments of tissue. On microscopy, it was seen that it is a gastric tissue. That is the first thing we look if they have really taken the intended organ or not. There was a chronic extensive ulcer covered by fibrinous exudate. By using terms have run in inflammation. Fibrinous exudate, it means it is rich in proteins, fluid, inflammatory fluid rich in proteins. If poor in proteins, you call it transudate. And then fibrin, there is a fibrin deposits. So below that, there was a fibrous tissue, meaning that it has been a chronic inflammation, there has been a granulation tissue. Elsewhere, the glands are hypoplastic and occasionally metaplastic, meaning that some of them, they had tried to be like the glands of the intestines. Because the intestines glands, they have a goblet cells. In the stomach, we don't have goblet cells. When we see them, we say there is intestinal metaplasia, as I said for the esophagus. So esophagus, we call it intestinal metaplasia, and specifically Barrett's esophagus. In the stomach, we just say intestinal metaplasia. So below the unulcerated lining epithelium, the stroma was diffusely inflamed. So as a conclusion, understand that there was inflammation, which was diffuse, with an ulcer which was perforated, and there was no cancer seen. So discussion, and we understand this is a case of gastric ulcer. This is what we are going to discuss. Chronic peptic ulcer. It is usually in pyloric type mucosa along the lesser curvature. So pyloric type mucosa along the lesser curvature. And when in most of the diseases affecting the stomach, cancer and the ulcer, they usually happen on the antropyloric area, and especially on the lesser curvature, just on the side towards the liver. That's why when you do surgery, you are not advised to pass through that area. So you pass through the greater curvature, because from there you can see clearly the tumor or the ulcer where it is. So when you do surgery, you pass through the lesser curvature, the greater curvature, not the lesser curvature. So 20% have coexisting duodenal ulcer, meaning they have both duodenal and gastric ulcers, and in 5% of cases they have multiple ulcers, meaning not one ulcer. So the mean age is 50 years, but it may occur even in children, especially if they are stressed, like those who are burnt or any other cause of severe stress. Males are more affected than females. multiple biopsy, at least 10, are recommended to rule out malignancy, because you can take 2 or 3 biopsies and you say they are benign, while there is another area which is malignant. But of course, I don't think this is an easy thing, because I said Sasha is the main center for endoscopy in Rwanda, but there are the times whereby they can't take a biopsy from the tumor. And when I ask them, they say, one specialist told me, I just saw the tumor, and I know I didn't take a biopsy from the tumor because I had fear. I was afraid of bleeding. So it is not just an easy thing to do. You can, yes, take a biopsy, but when there is a risk of having the bleeding that you cannot stop, then you are challenged to know what to do. So the symptoms are epigastric burning. Pain is worse at night with 1 to 3 hours after meals. Within 1 to 3 hours after meals. Pain will decrease with food, when you take food or alkaline solutions, meaning alkaline solution will neutralize the acid. So if there is a perforation, there is a back pain, and usually the pain can go up to the chest. So the reason why some people with gastric pain or gastritis, they think they have heart problems because they are close organs. So healing can be there within 15 years. You understand that it is a long period if the person was not treated. But if the person is treated, the healing will be just within few weeks. And here I understand the advantage of being treated. And of course, only they are treated, their problem is that it progresses to metaplasia and then cancer. Metaplasia, dysplasia, and then cancer. So the treatment, they use H2. This is histamine 2, type 2 receptors, blockers. And when you do this, you block the production of the acid. And also there is proton pump inhibitors. It means these are substances which will inhibit the pump of the protons. You know that the acid in the stomach is chlorhydric acid. In French, call it acid chlorhydric. I don't know how to call it in English. So it's the HCl, chloride and the hydrogen. So here, what they do is to inhibit the pumping of the hydrogen. So the complications are perforation, as in this case we are discussing, hemorrhage, obstruction, of course, because if there is a perforation, usually there is a peritonitis, then the organs will be paralyzed, stomach and intestines. And surgery will be necessary in most of cases. So on the examination, macroscopy, meaning using your eyes, usually there is a sharply punched out defect with straight walls. And these descriptions are very important when you do endoscopy to distinguish which is a cancer ulcer and what is just an inflammatory ulcer. So this one, they have sharply punched out defects and straight wall. Usually they're multiple, while cancers usually one. They have a sharp delineation or outline. They are oval, round, or linear. They are overhanging proximal and sloping distal borders, fibrous replacement of the muscle wall, subserosal fibrosis, and reactive lymph node hyperplasia. And this is, of course, seen on histology. So there is what you call hourglass stomach. Due to chronic peptic ulceration, there is a fibrosis and contracture here. So there is a ulceration, a chronic one, and the fibrosis yatumye hariya hikurura nk'ibyo umuntu yahiyemo n'akuntu uruhu rukurura. So bituma haba icyo bita hawa glass, nyango ni yari amasaha bamanika ameze kuriya afite iyi forme, niyo mpamvu bayise kuriya. So on the microscopy, of course, we look at the 4 layers. You see 4 layers of inflammatory steps. We have a purulent exudate, meaning it has pus, fibrinoid necrosis, granulation tissue, and fibrosis. So fibrosis will be deeper, and the most superficial layer will be purulent. We have a thickened blood vessels, hypertrophied nerve bundles, intestinal metaplasia. When it is there, it means that there is a risk that this patient may develop dysplasia and cancer in the future. And you can see evidence of peripheral degeneration. So as you know, most of the causes in our setting is the Helicobacter pylori infection. And I don't think this is an easy problem. In Rwanda, there are many cases. Almost everybody has Helicobacter pylori, and this is a very dangerous bacteria. It causes gastritis, ulcer, and cancers. Almost all the types of the cancers of the stomach are caused by Helicobacter pylori. And now the issue is that I was discussing with a pediatrician here, senior one, and he told me that when he's consulting in South Africa and any other areas, most of the children with abdominal problems, when they test for Helicobacter pylori, it will be positive. You give treatment, then after maybe 3 weeks, you check back, the control, you find it is negative. After some months, the child comes again with the same problem. So it is, of course, it is a communicable disease because you can transmit it to somebody else. So the issue here will be the hygiene. It is not easy to control. If maybe someone can have his or her own spoon or fork and the plate and so on, and practically that is not possible, especially when the children are at the school. And with that pediatrician who's also an infectious disease specialist, we are training to work with the Ministry of Education to just investigate more, especially in some schools, primary schools, and see the extent of the problem, and then try to find a solution to this issue. This is because, as I said somewhere, not in your class, gastric cancer is one of the most commonly diagnosed cancers in Rwanda, and no treatment except surgery. So being one of the most frequently diagnosed cancers in Rwanda and caused by Helicobacter pylori, we must work on this bacteria in the early age of the population, so that maybe in the future we may have a fewer cases. So we know some other countries such as Japan, who have very high prevalence of gastric cancer, they do a lot of research works on this. And we have started to work with them so that maybe we can find at least the reason of the problem we have in Rwanda. So in that context, we have our colleague, a pathologist who went there for 4 years for PhD training, just working on the stomach cancer issues. So probably in the future we'll have a solution. But it is really difficult to understand because in Rwanda they give the most potent antibiotics for this bacteria using the most accurate protocol, but still we have many cases of gastric cancer because of Helicobacter pylori. So the differential diagnosis will be ulcerated carcinoma. Of course, when they say ulcer, they take a biopsy in order to confirm if it is not a cancer. So on histology here, we have a remnant of normal mucosa here, and here we have dead tissue debris, so purulent, and then we have a granulation tissue here with many blood vessels. So comment, the gastric site of the lesion is not specified by the surgeon, and this is important also. They should say we have taken a biopsy from either, and you have seen the perforation either in the pylorus or in the antrum or in the fundus, was it near the lesser curvature or greater curvature? That is very important. So they said they resected a large tissue, but they submitted a small one. So meaning that if they submitted a very small biopsy and they have just thrown away a large tissue, who knows, maybe that part may be having a cancer. So the size of the lesion and this distance from the junction, this is margins, it is not clear. So usually they should say the mass was from, or the lesion was from maybe 5 centimeters from the distal margin, meaning gastroduodenal junction, or maybe 20 centimeters from the esophagogastric margin. So these were the comments. So this is how the ulcer looks like, and also the cancers. Usually it looks like this when it is very small, still small. So what are the risk factors for the stomach cancer? First of all, a patient with gastric gastritis with intestinal pressure, these are at very high risk of developing cancer. So that's why when they do endoscopy and they find, and in histology we say this patient will be followed up closely, maybe given an appointment after 6 months or 1 year to check. So another risk is the infection of Helicobacter pylori. Nitrates derived from nitrates, I think this I had mentioned. These are used in food and drinking water, as used as preservatives in prepared meats, those you buy from supermarkets and so on, which are pre-cooked. So they may undergo nitrosation to form nitrosamine, and the nitrosamides which are carcinogenic or cancerogenic. So diets containing foods that may generate nitrates, such as smoked foods. Abantu bakunda ibintu byokeje cyangwa bishiririye bimwe mu tubari n'ibindi. So, and those who take excessive salt, especially those who take salt which is not cooked, abawongera mu biryo ni ikibazo gikomeye. Decrease intake of fresh vegetables and fruits, because as you know, the vegetables and the fruits, they contain antioxidants, and these antioxidants, they help us to fight against cancers. So patients who have undergone partial gastrectomy and patients who have pernicious anemia that you learned in hematology, and this is caused by these patients, they have problem in the vitamin, I think B12, and this is, as you know, B12, it is reabsorbed when the person has intrinsic factor which works very well. So it is known that patients with pernicious anemia also they have a problem with intrinsic factor. And these data are from this book, Robin's Basic Pathology, that I mentioned when started. Robbins is a person who wrote the basic book that is used when you want to learn pathology, just general pathology. And he died some years ago, maybe in 2008, and because of melanoma of the eye. So the types of the stomach cancer, so then this is from both Robin's book and the World Health Organization classification of tumors. Do you have adenocarcinoma? Adenocarcinoma, there was someone called Roren. This was a pathologist or a medical doctor he was from Norway. And he has actually been working in Kilimanjaro Hospital, near Kilimanjaro, in Moshi, in Tanzania. So he's the one who defined how to classify the cancers of the stomach, because this classification helps much in determining the treatment and the prognosis of the patient. So you have intestinal type, meaning they have a glands, with lumen. Diffuse type, you see just diffuse cells. And this is very dangerous one. It harbors a very bad prognosis. And then there are some patients who have mixed type, both patterns. Another type is the gastrointestinal stromal tumor that I said. And the lymphoma, we call it mucosa-associated lymphoid tissue lymphoma or multi-lymphoma. Mucosa-associated lymphoid tissue lymphoma, and you have neuroendocrine carcinoma just arising from the endocrine cells. So this is the basic classification. But when you go into detail, there are so many subtypes that we cannot describe here. So any question about the stomach?
Excuse me.
Yes.
I've got a question on the clinical case that we've seen above about
Sorry?
I've got a question on the clinical case that we've seen above
Yes.
about the 28 years old person who went to the hospital, and the case was a perforated gastric ulcer. I want to know I want that you repeat the connection between the perforated gastric ulcer and the symptoms that the patient had, like having no gases, having no vomiting, and the anorexia, the connection between the two. Thank you.
Thank you. I think I had explained. The reason behind it, I said whenever there is something which causes inflammation within the abdominal cavity, especially peritoneal cavity, the stomach and the intestines will be paralyzed. That is a reflux. Whenever there is something, it can be a chemical, it can be an infection. When there is inflammation within the peritoneal cavity, the muscles of the stomach and the intestines will be paralyzed. Therefore, stools and the gas cannot pass, because for them to pass, they need peristalsis or movement of the muscles. So that is the reason behind it. So this person, if he had a perforation of the gastric wall, it means the gastric acid has reached to the peritoneal cavity. So that is the reason behind. And even when there is a perforation in the small intestine or large intestine, because the food will leak into the abdominal cavity, there will be a straightforward inflammation. And first, no gas or stool will pass through these organs. It is the same for acute appendicitis. When it has perforated also, there will be leakage of the stools in the abdominal cavity, and thus paralysis of these organs. And the gas and stools will not pass. The person will have just a very ballooned abdomen, and when you do auscultation, in a normal person, you will hear the movements of the intestines. But when there is such a paralysis, you will hear nothing, no noise in the abdomen. So meaning that there is a paralysis of the organs. Is that understandable?
Yeah, thank you.
Welcome. Okay, so we have a question. So can just type in the chat, cite the 4 most frequent types of gastric cancer.
Excuse me, teacher.
Yes?
I've got another question.
Okay, answer to this first.
To this, frequent types of gastric cancer, there is the adenocarcinoma, there is GI stroma tumors, there is lymphoma and neuroendocrine carcinomas.
Mm-hmm. Okay, you
Then
can go on.
the question I have the question about the people with constipation.
Yes.
They are mostly also suffering the abdominal pain. So I'm wondering if the constipation can be considered as the acute abdomen, or if it can be considered as the symptom of the acute abdomen.
It is not. There are different things because the constipation is usually a chronic issue. If someone has spent maybe 2 or more days without passing the stools, but the abdomen is not painful, that cannot be acute abdomen. Acute abdomen is usually it means the mode of its advent is that it's very quick and the patient has a severe pain and the stools and the gas can't pass. For constipation, at least I think they pass gas and the intestines they move because you can hear the peristaltic movements when you do auscultation. Which is not seen in acute abdomen. So in acute abdomen, there's a severe pain, which came just abruptly. There is a lack of stools and the gas, and the lack of movement, of course. So otherwise, constipation can be caused by anything. Just it's a mechanical issue around the rectum,
Thank
Is that
you.
right? Okay, thank you. So I think you had the answers from your colleague about this question. So any further questions about the stomach or esophagus? Okay, so we can take a break. I think 10 minutes is enough. Then we come back and we continue with intestines. Thank you.
Lally me after my feet.
Probably may have noticed is that there's increased numbers of cells. So not only will there be increased hematopoiesis or erythropoiesis really in the bone marrow, but there'll be an increased amount of erythropoiesis in places where normally you shouldn't have much, and that's the liver. So what are we trying to explain? Of the increased hemolysis in the baby, you have a tremendous increase in unconjugated bilirubin. Now, you know the liver conjugates bilirubin, and it makes it more hydrophilic and less lipophilic because unconjugated bilirubin is more lipophilic. So if you have a baby that has an extreme amount of bilirubin, which is unconjugated due to hemolysis, that lipophilic unconjugated bilirubin is more likely to be attracted by lipid substances like white matter, like myelin in the brain. And that's why babies that die of erythroblastosis fetalis have a bilirubin pigmentation in the white matter of the brain. This is what Kern icterus is, and I hope I did that one properly as well. We've gone through this again, but here's a little diagram to explain what's going on here with the most common type of immune hydrops. You have the Rh negative mother sensitizing her antibodies to the antigens of the baby, which are Rh positive. And basically, because these cells are hemolyzing, you are making up for it by having a high output cardiac failure, which is then when a human dies, tissues and organs die. When tissue and organs die, cells die. When cells die, organelles within the cell die. For example, the lysosomes may be seen to combine with things within the cell to digest substances within the cell by virtue of releasing lysosomal enzymes. The smooth endoplasmic reticulum classically becomes very, very activated in cell injury, death, apoptosis, necrosis as well. Mitochondria swell. They take water, just like the cell takes water. This is one of the first changes noted many years ago at the electron microscopic level. And when the cell is eaten up, it's not just the flesh of the cell, but the bones or the cytoskeleton is also digested. The thin filaments are broken down, the actin, the myosin, the microtubules, keratin, desmin, vimentin, neurofilaments, glial filaments, everything associated anyway with the structural skeleton of the cell eventually digests, hydrolyzed by virtue of apoptotic changes if it's part of normal cell replacement, or necrosis if it's a pathologic process. Things can accumulate within cells as well. And the classification of these is the entire classification of biochemistry: lipids, carbohydrates, proteins. Because fat washes out in the histology process using H&E, lipids are usually seen as empty spaces, whether they're round cellular structures or whether they're little slit-like structures like you see with cholesterol. Any proteinaceous
Camera Pro. Camera hiyo
Also, we can resume. So after esophagus and the stomach, now we go to see some typical examples of the diseases of the intestines and the appendix. So the disease of the small intestines, appendix, and the colon, they are inflammatory and malabsorptive disorders. This is the first class. So specific inflammatory diseases include infectious enteritis, such as having cholera, having dysentery, and so on. There is acute infectious enterocolitis, which affects both intestine, both small bowel and the colon, and a specific bacterial infection. There are other diseases such as Whipple's disease, celiac disease that I mentioned before, and it is almost clinically almost similar to Whipple disease. Tropical sprue syndrome, also it is similar to celiac disease, although it affects people in tropical countries. And ulcerative jejunal meaning that there is an inflammation of the jejunum and the ileum with many ulcers. Others are inflammatory and malabsorptive disorders are idiopathic inflammatory bowel diseases. These are ulcerative colitis and Crohn's disease, and you must know these two. Although we have a few of them in our country, but these are diseases you must know. There are microscopic colitis, meaning you see that clinically that there is a colitis, inflammation of the colon, but you will know the cause after microscopy. It can be caused by lymphocyte, so lymphocytic colitis, or if there is a deposit of collagen fibers. Diversion colitis, this is a colitis caused by urine. So diversion means there are some people who have problems in their urinary tract, and then the surgeon, what he or she will do is to divert the pathway of the urine. For example, the urine can come from the kidney directly to the colon, because maybe if the patient has had a cancer of the urinary bladder and the urinary bladder has been completely removed or completely destroyed, then they will have to divert the urine. And you understand the consequences is that because the colon was not made to contain the urine, then it will have a reaction to the urine, because the content of the urine and the stools are different. So there is a solitary rectal ulcer syndrome. There's radiation proctitis or colitis. Proctitis means that it is an inflammation in the rectum and anal canal. Diverticular disease or the diverticuli also they can happen in the intestines. So these are just examples. The second category, these are vascular lesions, acute intestinal ischemia. You just found that there is a gangrene of intestines. They are completely black, like when there is a gangrene of the foot in the case of diabetes and so on. There is chronic ischemic injury, angiodysplasia, vascularitis, and scleroderma. There is now specific disease of the appendix, such as acute appendicitis and the tumors. And here I would say that usually the clinicians, they think whenever there is a problem of the appendix, it's just appendicitis. This is just acute appendicitis. But we have seen some cases at Sashika, which are cancers, whereby the clinicians were just thinking about acute appendicitis. For us to find that they are cancers and the high-grade cancers. So intestinal polyps, they can be developmental polyps, meaning someone is born with them. And then inflammatory polyps, hyperplastic polyps, and neoplastic polyps, which we call adenoma when they are benign. So adenoma, they exist especially in a large intestine. Then malignant tumors, there are adenocarcinoma, carcinoid tumor or neuroendocrine tumors, gastrointestinal stromatoma tumor, and the lymphoma. It can be a B cell or B lymphocyte origin, mantle cell, bucket lymphoma, and the sprue-associated T cell lymphoma, meaning someone had sprue or that intolerance to gluten and so on, and then because of that they developed the T lymphocyte lymphoma. So this is just a brief list of the diseases which can affect this organ. So otherwise, there are many other. So the diseases affecting the anus, we'll discuss them after this part. So we start with a case study. This was a male patient, 46-year-old. So I removed his provenance. So he was admitted for sigmoid tumor with regional adenopathy or lymphadenopathy or lymph node enlargement. So they did the resection for curative purposes. So meaning they have resected the tumor, and usually you put a normal part of the organ so that to ensure that the tumor has been completely removed. So the differential diagnosis hypothesis was sigmoid carcinoma. So laparotomy was done. So they requested the investigation where histology to stage the tumor and document the margins and the status of lymph node. So we received the intestinal specimen with penetrating mass of 12 centimeter long. There are other tissue fragments of size 7 by 6 by 1 and 4 by 2 by 1 and 2.5 by 3 by 1 centimeter. So, and one small lymph node was separate. So the routine staining on the microscope, we found a typical gland infiltrating through serosa to the mesentery. So meaning that it is a cancer, epithelial cancer rising from the mucosa, perforating up to the serosa and even involving the mesentery. And there you can understand that it is advanced already. There is suppurative inflammation, which is also seen in the large fragment submitted. The excision margins were free of tumor. Isolated lymph nodes showed dilated sinuses with histiocytes, so meaning that there was no cancer cells there. So we concluded to adenocarcinoma for the colon, moderately differentiated, but the lymph node were not involved. They just showed just inflammation, chronic reactive lymphadenitis. So here there is a mistake. P is missing. So we did not give the stage of the tumor and the tumor board. The tumor board is a meeting whereby a pathologist, oncologist, and surgeons we meet and they discuss every case before deciding what to do. So the tumor board requests the clinicians to stage the tumor for further management options. So because the pathologist had given metastasis had to be staged by clinicians using radiology or by the endoscopy and so on. So if you discuss the adenocarcinoma of the intestines, first of all, we see the histopathogenesis. This is a normal colon mucosa, and then the mucosa at risk will have some methylation abnormalities or just mutations. So for example, there's a mutation in APC and beta-catenin, APC adenosis polyposis coli gene. Of course, when you see at the mucosa, you don't see changes. But as the times go on, now, if this mutation persists, the mutated cells are not killed or the mutations are not corrected, then the next step will be that further mutations will come, such as KRAS, which is at the chromosome number 12, short arm in the region area number 1, 2. Then there is the development of adenoma, which is a benign tumor, of course, with many other mutations in P53, a loss of heterozygosity at 18, chromosome 18, where there is this gene, SMAD2 and 4. Then after that, if all these are not cured, then there will be a carcinoma. So it means to have an intestinal carcinoma, usually it is a multi-step process, and that's why we call for the population to do screening. And the screening here will be mainly to do endoscopy to see if there are any adenoma, at least at this step, adenoma. They can be seen. If they are there, and then they do biopsy, they find maybe it is just a benign adenoma, they will do surgery and they remove it. And when it is a cancer, of course, at its early stages also it will be removed. And when it is small, then the patient will be, or the client will be told to come back after a certain period. So it means patient who is diagnosed at this stage will be cured without developing a cancer. And there is a syndrome called the adenosis polyposis coli here, or this patient, they have many polyps. And by convention, internationally, when a patient has at least 100 polyps, he or she will be classified as having this APC problem, even without screening for this gene mutation. And in such cases, the area which is involved by the polyps will be removed in order to prevent the happening of a cancer. So that is in general the pathogenesis of developing this cancer, and we shall see the risk factors.
Excuse me, Prof.
Yes?
At what time interval should people do screening?
It depends on the countries. So in Rwanda, there is an instruction, ministerial instruction, I think it was 40 years. So you can screen anytime, but as the government, what they allow you to use the public health insurance if you are 40 years of age. I will check the age. That it is between 30 and 40 years.
Okay.
But this is a good question. We previously, I had one postgraduate student, she now finished her studies. We looked at the cases of cancers that we saw at Esophagus in the past years, and we found many patients who were below 35 years, many patients, and they had in common a subtype of carcinoma called the mucinous carcinoma. And also I remembered that I have seen in Dar es Salaam many cases of gastric, of colon cancer of mucinous type who were around 20 years of age. So what we are doing now is to collect information if in the families of these patients who are below 35 years, if they have a predisposing factor in their genes. So once we have collected this information, we will negotiate with the Minister of Health to allow the members of such families to do screening before the age of 30 or 40 years, which is in a ministerial instruction. So they can be allowed to screen even at 15 years of age. But otherwise, the general population can be screened after, I think, 40 years in Rwanda. So it depends on the countries. that fine?
Yes, yes.
Okay, thank you. So what I was saying, it will be a robust study because we have to, first of all, we have a list of these patients who are young. So once we get the means, financial means, what we'll do will be to look at their gene mutations. And then for those from whom we find they have gene mutations, which are likely to be familial mutations, we will now go to their families and take their first relatives, first class, first order relatives, meaning their siblings, parents, or children, and screen them using a method that it is not used yet in Rwanda. And those whom we suspect they have now problems, we will go and take biopsy and check their mutation status. And then from that, we'll have a data to tell to the Minister of Health, this is what is happening, so please help these families and any other families in whom we diagnose mucinous carcinoma to be allowed to screen as early as possible. And we hope they will accept. So now we submitted that for looking for financial means because to test for gene mutation is very expensive. So the risk factors, there is a familial predisposition, as I was explaining. There is a diet and a lifestyle, diet rich in fat, poor in vegetables and the fruits. Lifestyle, of course, lifestyle goes with diet, but also those who are not moving, for example, those who sit in the offices and when they go back home, they go through cars, using the cars and so on. So who do less physical exercises. Also, there are those who have chronic inflammation. That's why I said, remember the two non-specific inflammatory diseases, Crohn's disease and the bowel and the ulcerative colitis, because these two, they are predisposing factors to intestinal cancers. There is irradiation. For example, someone has been irradiated for having cervical cancer, prostate cancer, gastric cancer, or any other abdominal tumor. Then these ones, they may develop intestinal cancers, rectal law. And it is data from this book, from the WHO. And these are books we use mainly when we diagnose the cancer. We use the terms which are within this book. Each system has its book, so that when any medical doctor or health professional who reads that report understands what we do. So we use universal terms. So the WHO classification of colorectal carcinoma, here we talk about carcinoma, and as we said, there are other types of cancers, GISTs, neuroendocrine carcinomas, and lymphomas. So here on carcinoma, you have adenocarcinoma, adenosquamous may happen, especially in the rectum, because in the rectum we have a granular mucosa, but it is very close to anus, which is an squamous cell epithelium. We have a mucinous adenocarcinoma, which I was explaining. We see it in very young patients in Rwanda, and we saw that this in other countries such as Tanzania also. Carcinoid ring cell carcinoma, it is a subtype of mucinous carcinoma, and these are associated with poor prognosis, usually. There is small cell carcinoma that is called hot cell carcinoma. Squamous carcinoma may happen, mainly when it is metastatic, and a differentiated carcinoma, and the medullary carcinoma, and the others. So if we talk about the adenocarcinoma, then clinical information presentation of these cancers, they are the most common malignant tumors of the large intestines. So here we are talking about the large intestine. So it accounts for 98% of all colon cancers, and accounts for 15% of all cancer-related deaths. So meaning that some which are diagnosed will not cause death. If they are diagnosed as early as possible, these patients will be cured. So the peak incidence is 60 to 80 years of age, but 20% occur at the age of less than 50 years. But these are global data worldwide. In Rwanda, it will be different because I think even more than 20% of the patients are below 35 years of age, according to the data I mentioned from South Africa. If in young patients, then predisposing factors must be considered, such as having ulcerative colitis, familial adenosis pori. This is the one I said, if we find in someone at least 100 polyps, they will diagnose familial adenosis pori. It means in his or her family there will be other members having this problem. There is also what we call hereditary non-polyposis colorectal carcinoma syndrome. Here it means it is hereditary, yes, but it is not hard. In this condition, they have no polyps. So it means we have two familial issues or hereditary issues. One is associated with polyps, another one with non-polyps, without polyps. So these are the two main predisposing factors, genetic ones. So majority are sporadic in nature, meaning sporadic, it means it is not associated with genetic or familial predisposition. Others are HNPCC or hereditary non-polyposis colorectal carcinoma. Others are FAP-associated carcinoma in about 5 to 50% of the cases of all. And so 5 to 15% of HNPCC. Okay, maybe I repeat it. So I said the majority of these cancers are sporadic. So meaning they are not familial predisposing diseases. So and this is because in all colorectal cancers, HNPCC are seen in only in 5 to 15% of cases, while familial adenosis pori associated carcinoma are seen in only 1% of all cancers. So in small intestine, it is true. It is very rare to see adenocarcinoma in small intestines. We see their gist and other tumors, but most of adenocarcinoma, we see them in the colon rather than in the small intestine. So within the small bowel, the tumor favors the duodenum, including ampura vater, and this will have consequences: cramping, abdominal pain, nausea, vomiting, and weight loss. Most of the cancers are located in the rectosigmoid region, and what we saw is that these mucinous carcinoma, they are mainly seen on the right side, while non-mucinous carcinomas are seen on the rectosigmoid, meaning on the left side. So this is what we saw at South Africa. And of course, those on the right side, they are associated with poorer prognosis. Icyambere kibitera nuko abangaba niyo agize bleeding bigaragara nyuma kubera ko bleeding from the right side will become up to the anus at a very advanced stage. Amaraso ashiramo hagati ntibigaragare, so bijya kugaragara byaratinze. And another reason is that most of them, they will be mucinous type, which itself harbors a poorer prognosis. Maybe what I can say here is that when we say a mucinous carcinoma in the gastrointestinal tract, you must understand that it harbors a bad prognosis. But when it is a mucinous carcinoma in the oral cavity, it harbors a better prognosis. This is just an observation. When you compare these types of cancer to other cancers, in the oral cavity, and the head and neck region, it is associated with better prognosis. While in the tract, gastrointestinal tract, it has a poorer prognosis. So on a gross examination, some cancers will be polypoid in shape, others fungating, they look like shortbread. So they can be ulcerative or infiltrative type. Infiltrative means usually on the surface you don't see any lesion. It is just within the wall of the organ. So these are the four microscopic or gross appearance of the colon cancers, carcinomas. So here there is a cancer which is exophytic. This is the outer surface of mesentery and the other things. Then the wall is here and here. So this is the lumen. This is the normal lumen, but here there is a mass. Here it is fungating because the surface is very irregular here. So they have cut through it. One of the complications of the carcinoma will be obstruction. Of course, as you see, it is growing in the lumen, fungating in the lumen. One of the complications will be to obstruct here. So the food or stools will not pass through very easily. So here the tumor was just infiltrating in the wall, but in the lumen you could see nothing, and in the outer surface also could see nothing. So the adenocarcinoma is well to poorly differentiated. I think these are the details of the pathologist, but you must understand when you say well differentiated, it means it is usually of low grade. While a high grade, it will be poorly differentiated, and these are very aggressive. They can kill very quickly as compared to the well differentiated ones. The subtypes, the variants, there is mucinous type, as I said. Here we will say that the tumor is mucinous if more than 50% of the tumor mass or the cells have mucin production. This is the meaning of this sentence here. If more than 50% of the volume of the tumor produces mucinous, we will say this is a mucinous type. Choroid type have a large extracellular mucinous pools with floating tumor cells. Tumor cells may not be abundant and often show syneth-ring features, and you have a syneth-ring cell type, mixed carcinoid and the adenocarcinoma type, meaning you have both the usual adenocarcinoma and the neuroendocrine carcinoma mixed in one tumor, mainly seen in the appendix. Then you have a small cell carcinoma, which is seen in older people, and you have adenosquamous type, which is very rarely seen. So this is the moderately differentiated adenocarcinoma. We have cells, at least you can recognize a granular pattern, and the cells are very blue. At least when the cells are very blue, what you will understand is that they have a more DNA production. So their DNA is being reproduced or replicated. So that's why they are very blue. So signet rings, vice signet rings kubera ko iba ifite akantu kameze nk'aka ziriya mpeta abadamu bambara, so nkaho habana nk'impeta nto akaza ka kantu kaba kariho ku ruhande, niyo mpamvu bayise signet ring cell carcinoma. So this is how they appear. And what you see behind here, ntabwo ari empty. This is mucin. This is mucin, where you see a fluid, something which is whitish. So for the staging, the principles are the same as for the previous organs, such as the stomach. For the stomach, I have not shown, but the principles are the same here as in the colon and esophagus. So staging, the grouping of the stage is based on the status of the tumor, the regional lymph node, and the metastasis. So comment, the preliminary staging should be done during surgery. Of course, when they are doing surgery, they should see if there are lymph nodes which may be involved, if the liver looks normal or not. Of course, they look at the surface. Radiology will be more informative in such case. The relationships or distance of the lesion to proximal or distal on the radial margins were not given in the case we had. The length for the submitted intestinal segment were not reported, and so on. So, any question for the colorectal cancer or any other disease of the intestines? Okay, so no question, then we go on. So list the two diseases that comprise the inflammatory bowel disease. Okay, so I can see if there's someone has typed. Okay, Mugisha, Elvin Mugisha has replied. Crohn's disease and the ulcerative colitis, right? So someone asked, can chronic peptic ulcer be the risk factor of gastric cancer? I think I explained this because the patients with untreated gastric ulcer tends to have metaplasia, then dysplasia, then cancer. Okay, thank you. So if there's no question, then we go to the next part. Okay, another question. Give at least two types of genetic alterations or mutation predisposing to colon cancer. KRAS gene mutation. Any other? This is Aquiline who replied it. So you read, but as I said, for the familial predisposing genetic alterations, we have seen adenosis polyposis coli in patients with familial adenosis polyposis, and then we have hereditary non-polyposis colon cancer. So these are examples. Then you have a specific mutation such as KRAS mutation, SMAD2 mutation, have P53 mutation, and so on. So the next part is the appendix. So a case here to discuss. This was a 21-year-old male admitted in ward for severe pain in the lower.
Excuse me.
Yes.
Can you come again with the answers for the last question, please?
Okay, you are recording, so you will have to replay that. So I said that there are those factors or genetic alterations which are related to the familial predisposition, such as APC or familial adenosis poly, and hereditary non-polyposis, colorectal cancer gene. So these are two familial syndromes. Then we have specific mutations which are not familial issues, such as mutations in P53, in SMAD2, in many other genes that you can see, including KRAS that someone here mentioned. So this patient was admitted in ward for severe pain in the lower abdominal pain, right lower abdominal quadrant. And this is important. Whenever you have a patient and they say there is a pain in the right lower abdomen, always think about the appendix. Right lower abdomen. Always think about appendix. He had also fever, meaning there is a kind of inflammation, vomiting, absence of gas and stools since 2 days. So you understand that the abdomen was distended. If the gas and the stools could not pass for 2 days. On the physical examination, the patient had the abdominal tenderness and mild fever. Investigations showed an increase in white blood cells count at almost 20,000. The normal is below 10,000. There was an increase in erythrocyte sedimentation rate, what you call in French vitesse de sédimentation, which is a sign that there is a generalized inflammation in the body. So there was also ultrasound of the abdomen to see what is happening. So after all this, they said this should be acute appendicitis. So then when you suspect this, because it is an acute abdomen, it is an emergency. You cannot say, so I will schedule surgery for tomorrow or after tomorrow. No. Whenever you say acute appendicitis, you must act directly. So they did surgery, then they did appendicectomy, and the sample was taken to histology. So it was the appendicular specimen, 8 centimeters long, 1 centimeter. There was an ulcer of 1 centimeter. So we have taken 4 blocks or cassettes. And on histology, the tissue showed extensive ulcerated and the necrosis of the mucosa. Extensive ulceration and necrosis of the mucosa, numerous neutrophils, lymphocyte, edematous stroma with many thin-walled congested blood vessels. And the conclusion was acute appendicitis, which is a most common disease affecting the appendix. But of course, I said there are many other diseases, including cancers, and we have seen a number of cancers of the appendix at South Africa. So if we discuss this disease, first of all, this is how the appendix is. It has a rumen, which usually it is filled with debris, stools, materials, and parasites, and so on. So we have a mucosa here, submucosa, and the muscularis externa and the serosa. So the acute appendicitis, tifaritis, it is common in Western world associated with high protein diet. So those eating meat are more prone to develop this. So obstruction happens in about 80% of the cases due to a fecality. Fecality is when there are stones within the stools in this appendix. These patients also so fecality is not a stone as such. So I was mistaken. So it is when the stools are very thick and very hard, looking like a stone, but the stone itself will be called a gallstone. There will be the obstruction may be caused by a tumor. It can be caused by the Enterobius vermicularis, these are the parasites, or diffuse lymphoid hyperplasia, especially in children. So these are factors which will cause appendicitis to happen. Of course, what we see in our settings, most of the cases, is just fecalis, meaning there are feces which arrive there and they have been impacted there. They could not come back from there to go to the rectum and the outside. So when it stays there for a long time, then it will cause inflammation. So the obstruction will cause the increase in intraluminal pressure. Then intraluminal pressure, when it is there, it is like now you compress the veins. If the veins are compressed, the blood will not pass through easily. Therefore, ischemia may happen. With ischemia, then you understand, after ischemia, there is necrosis. If there is necrosis, then perforation happens. And this can be accelerated by bacterial overgrowth and so on. So there will be periumbilical to right lower quadrant pain, nausea, vomiting, abdominal tenderness, mild fever, and leukocytosis. Increased CRP, this is C-reactive protein. So C-reactive protein is just an assay also which shows that there is a generalized inflammation. And this is not done in all hospitals. So it is done mainly in more advanced hospitals in Rwanda. So as I said, also there's an increase in erythrocyte sedimentation rate, which can be done in any health facility. Complications, there may be wall abscess in the perforation, and in this, 2% of the patients will die. So when you see a patient with appendicitis dying, you don't think it is a mistake of a medical doctor and so on. It happens. There can be a rupture, can be peritonitis, of course. Whenever there's a perforation and the rupture, the next will be peritonitis. Then peritonitis will bring acute abdomen, as I described before. So diagnosis, we say there's the acute appendicitis when you see neutrophils within the appendix. So when we see honorary lymphocytes, we cannot say it is acute, we say it is chronic appendicitis. So gross examination, when you do surgery, you will find there is soon the appendix will be congested, so looking like filled with water in the wall. Congested, often purulent serosal surface. Reddened mucosa on the cut surface, it will be red. And remember this reddiness, swelling, and so on. These are among the 5 cardinal signs of inflammation. There may be luminal pus, gangrenous necrosis of the muscular wall, and there may be or not perforation. On the microscope, as I said, we must be neutrophils in mucosa up to the muscularis propria. So this is the appendix. So the length is not a problem. Now the problem is the thickness. So this is too thick, and when you see it, it is as if there is something ballooning it within the wall. So these are remnants of normal epithelial cells. Otherwise, all these are inflammatory cells, neutrophils, and within a fluid, so meaning there was edema. And when there is a necrosis associated with this, we say there is a purulent inflammation of micro abscess. So differential diagnosis, when there is acute appendicitis, you may find a cause, but in most of cases we don't do. So it can be caused by Yersinia enterocolitis. These are microbial agents, parasitic infection, such as amoebiasis and schistosomiasis. I think in the last years we had a case caused by schistosoma, especially if we see many eosinophils instead of neutrophils as inflammatory cells. We will think about parasites. Crohn's disease and ischemia also may be a differential diagnosis. So, any question about appendicitis or any other disease of the appendix? Okay, so we proceed with this part. So we start with a clinical case. A 40-year-old male admitted for anomalous suspected to be hemorrhoids. So investigations show the biopsy has been sampled from the anal region. Then what was seen on the biopsy, it was a soft skin covered tissue, meaning that it was partly covered by skin. Size was 3 centimeter diameter. Cut section showed multiple brownish areas. Histology, it was a nodule lined by stratified or outlined by stratified squamous epithelium with fibrocollagenous congested dilated blood vessels, focal stromal edema, and hemorrhage. So what is important here is these blood vessels. They are dilated and filled with blood. When you say congested, it means they are filled with blood. And then, at conclusion, it was hemorrhoids. These were hemorrhoids. So they look like varices in other areas. So in the anus, they would be called hemorrhoids. No cancer was seen. So the hemorrhoids, this is where they are usually seen in this part. Internal hemorrhoids can be there, and then external hemorrhoids. So internal, it means you will feel it when you do digital rectal examination, while the external one, you can see it outside. Even the members or the neighbors of the patient they can see it when they are looking at that patient. So this is just anatomy. You know that the anal canal is a tubular structure along 3 to 4 centimeters. There is no peritoneal covering, of course. It derives from the cloaca, distal hindgut. This you have seen this in embryology. So there are types of definitions of the anal canal. Classic anatomic definition and the American Joint Committee on Cancer definition and the histological definition of the anal canal. So this is a matter of anatomy. So the drainage, it has a regional lymph node. For the arterial supply, there is a superior, middle, and inferior rectal arteries. For the venous supply, you have a superior rectal vein. So we have histological types of in the anal canal. You have a glandular part, which is proximal. You understand this is the just closer to the rectum. That's why it is glandular. Transitional, it is intermediate between squamous and the glandular. And then we have a keratinized and the non-keratinized squamous, which is distal, just continuous with the skin. So it is logic. The distal part is similar to the skin, so squamous. The proximal part is almost similar to the rectum, which is on the proximal aspect of the anus. So there are many other descriptions here. So this is how hemorrhoids will appear on examination. So I think if you meet a patient with hemorrhoid, you will not miss this. So first of all, they are irregular nodules, and they are black to red, depending on the quality of the blood they contain. If the blood has been stagnant for a long time, it will be clotted and will look blackish. If it is a fresh blood, it will be reddish. The causes are processes causing deterioration of connective tissue and smooth muscle that anchor anal submucosal venous sinusoids. And other reasons, they are chronic constipation. Kukonayo is that if stools are there, they compress the veins, and therefore they will have a negative impact on the venous return. But also chronic diarrhea, because these are people who will always be pushing stools to go, so their veins will be also distended with blood. Pregnancy, this is because the pregnancy, I think I mentioned last time, will have an effect, a compression effect on the inferior vena cava, and therefore the venous return will be compromised. This will cause the blood to stagnate in different parts, the lower limbs, and anal region. There are other regions such as portal hypertension and so on. Rarely granulomas, condylomas, tuberculosis, herpes, syphilis, and many other infections may be the cause of that. So portal hypertension usually will lead to the bleeding of these hemorrhoids. So symptoms here may be bleeding and pain if these veins are thrombosed. And usually this is what brings the patient to come to the health facility. So this is a grading. We will just read it. Grade 1, 2, 3, 4 of the hemorrhoids, and the findings if you examine, and the symptoms, and how you will go on to treat. So you see that when it is a lower grade, they can just change the diet and the other lifestyle habits. But when it is advanced, then you have to do hemorrhoidectomy or surgery to remove these veins. So on histology, so this is a connective tissue with some of these whitish areas. These are adipose tissue, but you see blood vessels filled with blood. And here the blood is somehow fresh. Here, this was the blood. Now it is no longer, you can no longer see red blood cells here, except here we have a few of them. So this is a thrombosis because a clot has been in there for a long time. So, and this is the one which will cause the pain. So that's all for this presentation. Any question, you ask it. Otherwise, we take a brief pause and then resume after maybe 10 minutes to another part. Question?
Yes.
Yes,
I have a question.
lecture.
Yes? Are you talking? We don't get you.
So lecturer.
Yes, you can go on.
So then what is the difference between the hemorrhoids and the anal fissures?
Ano?
Anal fissures.
Anal fissures, they are different. Hemorrhoids is a problem of the vessels, veins which are filled with blood, which has been stagnant there for time, sometimes being thrombosed. While the fissures, they are like ulceration, so they are ulceration which can be caused by anything else, traumatic and so on. And maybe this is also seen in nowadays habits with this gay, call them gays, our thing, so they are quite different things. They have nothing in common. Although when hemorrhoids, it can be ulcerated and then look like fissures, but they are quite different in pathogenesis and in clinical aspects.
Okay, thank you.
Okay, thank you too. So there are other diseases that we cannot discuss everything, but with the HIV advent, there are some patients who develop what we call condyloma acuminata because they have a low risk HPV infection. Human papillomavirus, which cannot cause cancer, but will cause benign tumors, which look like a souffle, so the cauliflowers. So you will see it in the HIV patients, especially those who don't take antiretroviral drugs.
A question.
Yes.
We've not seen so much on the stages of hemorrhoids. I want to ask, like, the complications which can develop from the left untreated hemorrhoids. Like, for example, if a person has the external hemorrhoids which are left untreated, are there some complications that can develop?
Yes, the complication, they can be ulceration, I mentioned after. Ulceration is one of the complications. Otherwise, there is no risk for it to become a cancer. There is no connection to cancer. It can be just ulceration and the hemorrhage, of course, outside. And I think they said when it is associated with portal hypertension, it is when it bleeds more. I think we mentioned this. So otherwise, there are no deadly complications as such, especially if there is a negligence. For example, if there is a hemorrhage and a person doesn't go to the hospital, they can lose blood and die. But otherwise, there are no deadly complications.
Yeah, and I have another question.
Hmm?
About how can we differentiate from the hemorrhoids and the rectal polyps?
Yes, sometimes it can be difficult, but as I said, for the hemorrhoids, they occur how they are, reddish or brackish, depending on the stage of the hemorrhoids. For the polyps they are from rectum, of course, they are rectum, and they will be covered by the rectum mucosa usually, and the color of course will be different. Of course, as I said, it can be difficult to distinguish them, and that's why you will have to take biopsy, and then on histology, everything will be sorted out. And I think there is a time also we received a specimen. The doctors were thinking it was a hemorrhoid, but we found it was a cancer. So it can happen.
Thank you.
Thank you. So we take a 10 minutes break, then we come back.
wahereye saa mbiri yewe waje natangiye classe saa tatu narangiye.
And also, I hope you are back. So we resume our lectures. Now start the head and the neck pathology. It's just a continuation of the alimentary tract, but here we see some other organs which are not part of the alimentary tract. So head and neck pathology is composed by many organs. So, but in summary, we see the developmental abnormalities in general because there are some developmental abnormalities which affect different organs at the same time. And then we shall look at the tumors of the jaws, the eye, the ear, and the salivary glands. So that's in summary what you can see. So, but when you read the books, we see that sometimes there are other organs which are considered as a part of head and neck, such as the disease of the nose, diseases of the oropharynx, oral cavity, and so on. So we cannot discuss everything, and some of these will be covered in other chapters. So thyroid also included. Thyroid here we discuss it in endocrine diseases instead of head and neck. So it depends on how someone has decided to classify these organs. So the developmental disorders, they are due to a failure during the process of cell division and the differentiation into various tissues and structures. So some may be identified clinically by radiographic examination, by biopsy or histological examinations, and the others will just need genetic assessment or assays to know that they're there. So what are the types of developmental disorders? The first category here is inherited disorders, meaning that they are inherited in the genes that we receive from our parents. So this is these are just definitions, not the types. So these are called inherited disorders. So a congenital disorder, it is the disorder that is seen at birth. It can be either inherited or developmental. So meaning that can be caused by genes you inherit from the parents, or it can be just due to the developmental defects that happened in utero, but which were not just from the genes from parents. However, the exact cause of most congenital abnormalities is not known. Genetic factors, these are malformation often due to a genetic factor such as chromosome abnormalities. And of course, this can be either inherited or non-inherited. Environmental factors, these are also called teratogens. They are the ones that can cause so someone can this can lead to infections, drug exposure to radiation. So the disturbances in the development of the jaw, lips, palate, and the tongues, we see some of them here. So disturbances in the development of the jaw, lips, palate, and the tongues. So I think there are many abnormalities that we shall not talk about here, and some of them are considered like good things, ahantu hafite inyinya urugero you consider it as a very good thing, beauty and so on, but in medical setting it is considered like a developmental abnormality. So I hope you can hear me. So the system is saying a connection of pure quality. Do you hear me? Okay,
Yes.
Yes.
Yes, we do.
So here we start with features of Down syndrome. You have seen this in the genetics. So Down syndrome, it is trisomy 21. It means someone this person has 3 chromosomes, number 21. So there are many consequences for that. But clinically, what do you see? You see brachycephaly, a small head. And you understand when a head is small, the brain is small, and there is impairment of the intellectual capacity, if I can say so. So other signs are the epicanthus and flat nostril, bleached, hypoplastic maxilla. So the maxilla is small as compared to the mandible. Appusenting palpebral fissures. So Amasana are oblique, like you see here. Instead of being somehow horizontal, this is like this and here. And microtic, meaning they have very small ears, low, and they are a low set. So you see as if they are almost at the neck instead of being at the head. Macroglossia, meaning large tongue with glossoptosis. So meaning the protrusion, optosis, yes, referred to protrusion of the tongue. Glosso is the tongue, you know that ophthalmoptosis is like the when the eyes they seem to come out of the globe and come outside. So there's the brush filled spots muri iris abafite utuntu tumeze nk'utubara. There you see the fingers and the toes, how they are. And hano mu kiganza agiramo similar grace ngira ngo tugomba kugiramo imirongo ibiri ariko umwe usa naho uri nk'ibiri ka 30 ariko uyingwa hano garagara n'umwe. This is another feature. Excessive nucous folds asa n'afite uruhu runini ku gikanu. So these are but it doesn't mean every person with trisomy 21 will have these signs. So some will have a few of them, others will have all of them. Another thing, as you run in genetics, is that there is what we call penetrance and in other terms. So meaning that some children will manifest this at birth or soon after birth. Others will just manifest this after many years. So penetrance means the degree by which someone with a genetic effect will manifest clinical signs or manifestations of such a genetic issue. So that is in summary trisomy 21. But you know its consequences, of course. Here it comes here in the head and neck pathology because most of the signs and symptoms related to this syndrome are seen around the head and in the neck. And the other consequences, these patients, they are more prone to develop leukemia, especially acute myeloid leukemia. Last week we have seen hematopathology, so you know what is leukemia. And this is one of the causes of them dying early, around 4 or 5 years of age. So it is not usual to see some of them being adults. So this is one of the syndromes. Another one, features of a disease called the Cruzon syndrome. They have autosomal dominant mutation in fibroblast growth factor receptor 2 on chromosome 10. So there are signs. You see exophthalmos, of esophthalmos, ngira ngo nibyo ushize nashaka kuvuga kuri amaso asa n'aturumbuka. Craniosynostosis. So here their problem is that the bones of the head, muzi ko habamo ibyo twita fontanelles, ni ahantu haba hafunguye amagufa azaterana umuntu akuze. So awo yifunga kare. So when this happens in early ages, ubwo ntabwo ubona aho bukurira. Ariko Imana yabirekeye kubera kugira ngo uyu mwana avutse ubwonko bukomeze bubone aho bukurira, amagufa agende yegeranye. So iyo ateranye hakiri kare ntabwo buba bugikuze. Then you understand the consequences. Others are the strabismus cyangwa imirari nyangwa niko mubyita, aho amaso ubona atari kureba ahantu hamwe. So others are ngira ngo bafite byombi. Hyperterorism ni ubwoko bwa strabismus, ariko noneho aho strabismus hari igihe amaso aba areba yose akonverejamo hagati, ariko iyo areba atandukanye babita hyperterorism. There is this I think it is a problem on the shape of the nose, which is very difficult to appreciate here. Hypoplastic maxilla, nkuko twabonye no ko hejuru, uyu maxilla hejuru abona ko bisa naho ari gato, mandible iragaragara ariko maxilla iragaragara. So rimwe na rimwe hari indwara ubona ukagira ngo hari abantu bazirwaye bitewe n'uko baremye, usanga abazungu ubona ko bagira maxilla ntoya, so on so but when it is exaggerated here, then we say there is hypoplastic maxilla, and as a consequence there is mandibular prognatism. So mandible ukabona yabaye nini cyane, ariko this is a relative, it is because the maxilla is very small here. So can you hear me now? Okay, so I had
Yes, you
lost.
can.
Thank you. I had lost internet.
Yes.
So we were done with the cruise on problems, especially with their eyes, how they look like, and the small maxilla and the prominent Sorry. Okay, so it seems there is a problem with internet. Don't know what is happening. So I was saying that for the Treacher's syndrome, Treacher's Collin syndrome, there are some similar signs as those we saw in the previous syndromes, like downward slanting. But I think here it is the opposite to the to what we saw to the trisomy 21, because in the trisomy 21 the eyes were oblique on this sense, and here it is the opposite. This is a downward slanting, while in Down syndrome it was upward. Mara hypoplasia, this area, and then hypoplastic supraorbital limbs, so they are small here, and the lower eyelid corobomas, so they have some sense here, but it is difficult to see here, and there is mandibular hypoplasia. So in the previous syndromes, in the Cruzon syndromes, there was maxillar hypoplasia. Now here there is mandibular hypoplasia, so it is the opposite. And then auricular malformation, as you had seen in Down syndrome or trisomy 21. So they share somehow. There's another syndrome called golden hair syndrome. So they have partial microsomia. It means one part of the face is well developed, and another one is smaller, as you see this. So this is less developed than the right side. So upper eyelid coroboma, in the previous one, the coroboma was in the lower upper lids. And there is a mandibular hypoplasia, and this is the same as in the previous syndrome. Microtia, meaning they are small ears, and the preauricular tags. So to begin with, to react. So another problem they have a bulbar dermoid masses. So just above the eyes, they have it. This dermoid is a cyst, so small cyst there. Those findings. Ocular finding, it means when you see this child and this old person, all of them, they seem to be thinking hard, but this is not the case. They are always like that when they are not sleeping. That's why they say this sign is called ocular finding. It is as if they are finding something with the eyes or thinking about something very deeply. They have a massetal abdominis and cleft palates. There is another one called Beckwith-Wildermann syndrome. They have a macroglossia, a large tongue, midline abdominal defects, ugasanga yavutse wenda ubona Still internet issues. So macrosomia, meaning the child looks like obese. This neonate, they have ear pits and creases, usanga afite mukobwa cyangwa se bimeze nka fissures mu matwi, and so on. So there is a syndrome now. This maybe you will be finding it every at least once a week. Patients who come having some spots on their skin, anywhere on the skin. So there is a syndrome called this one, Leckling-House syndrome. So these are patients who have a mutation in a gene called neurofibromatosis 1. So they are characterized by many things, including intracranial brain tumors and the meningiomas. And also they tend to have many spots on their skin. So it is almost normal to have a spot or even a small nodule, usually which are dark on the skin. But when someone has many of them, then it becomes an issue. So cutaneous neurofibroma, like these masses, will be cumbersome. When they are not nodules, they are just a change in color. We call them like a carré of spots, café au lait. Sorry, café au lait spots. Café is coffee, lait is milk. So it is if someone has a white skin, these spots will look like a coffee, which can to stain in the milk. So axillary frecklings. So we have also there's a dark colored discoloration. Then we have a plexiform neuroma. Plexiform, it is a term which will be confirmed on histology, because there are things we look into the mass, and if we find them, then we say this is a plexiform component. There's these patients also, they tend to have optic glioma. Glioma, as you know, it is a benign tumor arising from astrocytes. It can be malignant, but usually when they say glioma, it will be benign. Otherwise, they will say glioblastoma. So this is an MRI or a CT scan. So you see one eye here and one eye here, but around this eye, you see that on its optic nerve, there is a solid mass. So this is a glioma there. So there are these nodules you see around the iris, in the eye, and here we have long bone. So mugasanga, this I think it can be tibia and radius, tibia and fibula. They are both cyangwa se bikaba no ku maboko cubitus and radius. So yaragoramye. So these are some of the signs. Otherwise, this disease will come now and then as we go on discussing different diseases. So it is a syndrome. Then in a syndrome, you can have many diseases arising from it. So the patients will develop a neurofibroma, others will develop meningiomas, others will develop what's called schwannoma, and so on. So for neurofibromatosis type 2, they have a mutation in the gene called NF2 or neurofibromatosis 2. Also, they have a café au lait spots. They have a schwannoma. Schwannoma, these are tumors arising from Schwann cells. And Schwann cells, you know them, they are like oligodendrocytes, but oligodendrocytes exist in the central nervous system, while Schwann cells exist in the peripheral nervous system. But their function are the same, is just to quicken the transfer of the information, the neuron. Subcapsular cataract, meaning a cataract within, just beneath the capsule of the lens, and they develop also meningioma. So you see that neurofibromatosis type 2 tends to be associated with tumors in the intracranial area, while the other one was just around the skin, the neurofibromatosis type 1. So this is a person who have these are eyes, and then you have tumors inside the brain here, and so a tumor here, and there is another tumor here, and they have this cataract in their lens. So that is in general what you can say about the different disease syndromes, developmental syndromes that can be associated with head and neck abnormal appearance. So non-odontogenic cysts. Now, these are cysts which are not related to the teeth development. This is because most of the cysts around the mandible and the maxilla are due to abnormal development of teeth. So we find people who have less teeth, meaning that there are impacted teeth which has not erupted. They are prone to develop some cysts. So what is listed here, they are cysts, but which have nothing to do with teeth or tooth. Among them, we have nasopalatin canal cyst, median palatin cyst, median mandibular cyst, nasolabial cyst, branchial cleft cyst, and this is very common. We see it many times in the hospital. There's a dermal cyst. This can exist anywhere on the skin, but we see many of them on the neck. Dermoid cyst and the benign cystic teratoma and the thyroglosal tract cyst. This also we see sometimes. And when we see thyroid tissue in it, it helps us to distinguish this tumor with the branchial cleft cyst, because for the other features they look the same. So we will see or discuss a few of them. So the branchial cleft cyst, which is also called the lymphoepithelial cyst, meaning that in it has both epithelial and the lymphoid. So here is the lymphoid tissue, then these are epithelial cells. Then there is a cyst filled with keratin debris. Then they distend that space and it becomes a very large cystic area. It is most commonly found in the major salivary glands with a stratified squamous epithelium lining surrounded by a well-circumscribed component of lymphoid tissue. So it is what is seen here with epithelial cells here and then a lymphoid aggregates here. So the most commonly it is found intraorally on the floor of the mouth and the lateral borders of the tongue. Clinically, it looks like a pinkish yellow raised nodule. So when you see a nodule intraorally, you can think about this. But most of the time, when you see a nodule intraorally, it can be a squamous cell carcinoma, and that is the most common diagnosis when there is a nodule there. So don't be mistaken that it is just a benign cleft cyst. It may be a cancer. Surgery, they must do surgical excision. So a thyroglosal cyst is a developmental abnormality, as you learned in embryology. It is said that the thyroid gland develops together with the other parts of the oral cavity, but as the embryogenesis goes on, the thyroid will migrate to go lower on the neck, on the anterior aspects of the neck. So sometimes then there are some parts of the thyroid which are left behind here. And when someone is grown, there's a part will now and develop, become large, and thus producing a kind of tissues looking like a thyroid. And thus it will be, because it will be in abnormal position, then it will be clinically seen as a mass, and the biopsy will say this is just a thyroglosal cyst. Thyroglosal meaning there's a tissue of thyroid and tissue of the tongue. Most often found in individuals are under 20 years of age. there's homosexual direction, so meaning that both of sexes are equally affected. Treatment will be also excision. Aneurysmal bone cyst, this can exist in any bone. It doesn't exist only on the head and the neck area. It can exist in any other bone. So that's why you hear it about in different other disease causes such as orthopedics and so on. So the first of all, it is a pseudocyst. So in histopathology, we say bustedocyst when there is no epithelial lining. So we see a cystic cavity with cystic content, but there is no epithelium. So in that case, we say there is a cyst, but it is not a true cyst. So on the radiology, on the radiographic examination, it will be multilocular. It means it is like having a lot of vesicles inside. Honeycomb soap bubbles. It will look like a soap bubble. Usually seen in a person or less than 30 years of age. Slight predation for females, although no known mechanism for that. And the treatment will be also surgery. So any questions so far about this? So then we continue with the tumors of the jaw. So there are malignant tumors. Of course, as you know, malignant tumors will destroy surrounding organs, causing ulceration. They are irregular in surface, and also their borders or margins are irregular. So malignant tumors, the classification can be histogenic. For example, some are of epithelial carcinomas or connective tissue origin or muscle and so on. Histologic, depending on the degree of differentiation, well differentiated, moderately differentiated, or poorly differentiated. So this person is showing has a problem inside here, a tumor. This one is having a tumor on just a neck, on the outside aspects of the neck. So behavior, the benign tumors, as you know, they grow very slowly, while the malignant ones, they grow progressively, sometimes quickly. They invade the surrounding tissues, and they are associated with high mitosis rate. There are intermediate tumors, which show features of benign and malignant tumors at the same time. So, oral lesions, most of them, they are carcinomas, and 90% of them, they are squamous. There are some secreting cells, epithelial cells, epithelial cell carcinomas, which are called adenocarcinomas. So here you see, I think it is the same tumor coming back here, which is ulcerated. So most of ulcerated tumors will be carcinomas. This child is having a big tumor here. And I think this is a tumor that you know, bucket lymphoma, which was discovered for the first time around us here in Uganda in 1958 by a medical doctor called Burkitt, Dennis Burkitt, and he was a missionary from the United Kingdom working there. Then he saw many children around 7 years having the jaw tumors. And he said, I have seen many children, African children with sarcomas. He took biopsies, specimens, he sent them in UK. And there has been a problem with flight delay. Airplane didn't arrive at the time. And the specimen maybe was taken through many other airplanes, and it arrives there after 71 days. And when it arrives there, they thought maybe this is infectious because of how it was appearing. So they took some part of the sample and they cultured in the microbiology, and they found there was a virus. And the persons working in that laboratory, one was called Epstein, another one Barr, and another one Achon. So they discovered the virus was called then Epstein-Barr virus. And they say it is a lymphoma. It is not just a common sarcoma. It is a lymphoma. So the lymphoma was called then bucket lymphoma. So it is known to affect children around 7 years, and in tropics where there is malaria and Epstein-Barr virus. And in Rwanda, at least we know that everybody, including children, small children, they have been infected by Epstein-Barr virus at any time. So this I saw it personally because in a study we have done, we just sampled blood from leukemia patients, from healthy donors who were just giving their blood for transfusion, and we found that everybody has been in contact with Epstein-Barr virus at any time. So other tumors are sarcomas, and here we see mainly rhabdomyosarcoma, the cancer from the skeletal muscle. And this in Rwanda, you know that it is treatable, it is treated because it responds to the drugs which are available here. Others are lymphoma, of course. So the early diagnosis is very essential for the management. Otherwise, I think even last week, not last week, this Monday, we had a case whereby we in ENT or ORL, they have seen a patient around 20 years of age. Yes, she was born in 1990, so 32 years. So she had a big neck mass, but when they did also examined the larynx and so on, they found that there was a mass there also with ulcer. So for them, they say maybe if it is a carcinoma from thyroid, we can treat. But if it is a carcinoma from the squamous epithelium, we cannot treat because it is too advanced. And we told them it was a squamous cell carcinoma, so meaning that it is palliative, they cannot do surgery. That's why then I say early diagnosis is very essential for the management. When the patients come very late, no other alternatives than to tell them to go back home for palliative care. So clinical diagnosis from the signs and symptoms are important. As a clinicians or general practitioners, we must say at least differentiate, distinguish benign from malignant lesions. So referral is essential for further investigations. So when you are stuck, you can't give a final diagnosis, then refer the patient at a time. Referring a patient is not a weakness of a medical doctor. Referring a patient means you know the limits of the setting, not necessary limits of yourself or your capacity, just the limits of the setting where you are. If you cannot do histology or CT scan or any other investigation, then you refer the patient as quick as possible. There is no reason to delay the patient. So transferring a patient is not a weakness of a doctor. For me, it is a sign of being strong in what you do. So the rate symptoms may be pain due to secondary infection or nerve involvement, excessive salivation, difficulty in deglutition or speech. So some of these patients, they can't speak, hemorrhage and so on. If the bone is involved, usually it is painless and so on. So there are many signs. So I think here now, these were the general concepts. Otherwise, we will come back on these tumors, on some specific examples. And here we will start with the tumors of the eye and the adnexa. It's adnexa, of course, the eye, and it's adnexa. So any questions so far? So if there's no question, then we can take a break and come back at 2 because I cannot start this because there are many things to discuss here. So better we discuss it as a whole. So let's resume at exactly 2 p.m.
Yes, yes.
Oh, not good.